Hey, good afternoon, everyone, on this beautiful Thursday afternoon, going into what looks to be finally a really nice weekend. We are really excited and happy to welcome Sean Rocket to the hot seat today on our Lunch and Learn series, helping clinicians with knee pain. Next slide, please, Sean. Just want to tease upcoming Lunch and Learns. We have a full battery through the month of June. We have next week, your role in data integrity. This is going to be a great talk about how we deal with our Epic notes, given the open note format and everything else in that regard, and how we change notes. So please feel free to tune into that. On the 17th, we have a carotid stenosis talk. And then on the 24th, we are really happy to welcome Alan Whitcower, who runs our Ballant group, which hopefully he could talk a little bit about as well. Talking about, hey, doc, the pain is in my back, not in my head, behavioral medicine and low back pain. Next slide. And we just want to remind folks of the physician wellness programs that we continue to run. Our physician care concierge program, where you can log on to communities.circles.com, get a free year of advice for anything you need, from planning a party to grouting your tub to shoveling the snow or mowing your grass. They vet people and they will give you 2 or 3 local resources for you to call. We also have our weekly virtual meditation classes and our virtual yoga classes that are available for folks. And on the fitness end, the 1-year free membership to the Peloton app. You don't need a bike or a tread. You can just join the app for a full year. Please feel free to do that, as well as our online coaching through Daniel Destin at the Shipley Fitness Center. We also want to just point out Kathleen Servan has joined our team, and she is now the contact for the Peloton membership, and her email is posted here. Next slide, please, Sean. And next Thursday, between 8 and 12:15, we have our 5th annual Mass General Brigham Patient Experience Summit. We do welcome folks to log on to that. There is CME credits available. Next slide. And all yours, Sean. Thanks.
Thank you, John. It was tremendous. You could be work as a DJ if this medical thing doesn't work out. So starting today, we're going to talk about knee pain. It's going to be basically very casual, a lot of pictures. My name's Sean Rocket. I see a lot of friendly names on the Zoom list. I'm orthopedic surgeon for the CrossFit Games, specialize in shoulders, knees, hip and knee replacements, workers' comp injuries. Happy to see all your patients here at Orthopedics New England. We've grown to a group of 17 surgeons with physician's assistants, covering everything for orthopedic needs from head and neck to toes. There's our backline number if you need it. And Denise Spring is our brains behind the organization, and she can help if you have any questions trying to get access to us. So starting with the knee joint, I started this website called 321gomd.com, and feel free to go to it at any point. It's got nice pictures for anybody with a frozen shoulder. It shows pictures. Anybody with calcific tendonitis, it's got nice pictures, so you don't have to sit there and show people with your fingers what a meniscus tear looks like. So feel free to go to that. And some of these presentations are off 321gomd.com, so you're welcome to check that out. So basically today is really about just keeping it simple. That's kind of the way I like to do my golf putts. Basically, we're going to get into some of the, right off the bat, the pearls of the knee joint and really the history behind history taking that you can get. Basically the diagnosis of talking to somebody just by where they're pointing to and what they're saying. So the pearls are basically, if you look on this slide, pain in front of the knee. It's really simple. It's really either the kneecap or the patella tendon typically, and it's either tendonitis or arthritis. And that's right off the bat. Somebody comes in and they're pointing, to the front of their kneecap. Pains on the sides are usually meniscus, or in the back. The meniscus is most commonly pain in the back of the knee. Somebody feels something moving inside the knee, that's usually meniscus or a loose body. And then buckling or giving way after trauma is usually a ligament tear like the ACL or a meniscus. And then buckling with no trauma, that could be meniscus also. You don't have to, you can have a degenerative tear of the meniscus or arthritis. Arthritis can cause the knee to buckle and give out. Other things about swelling, looking at swelling, huge amount of swelling after trauma is typically either the ACL, a patella dislocation if they're a younger person, or a fracture. Mild swelling after trauma, typically the meniscus will give you mild swelling, or even just a bone contusion. And we'll talk about that, what a bone contusion actually looks like. Huge amount of swelling with no trauma. Somebody comes in, huge amount of swelling. That typically is either gout, pseudo-gout, or Lyme disease. And again, these are generalities, but this is sort of just what I see in general. And then again, minor swelling without trauma, arthritis can do that, certainly. And then fever, if somebody has a fever, usually gout, pseudo-gout will give you a low-grade fever around 100 or so is what I've found. And then septic knee usually is around 102, like 102, so pretty significant fever. Right off the bat, this is off that 321gomd.com that you're welcome to go to. This is, the important part of this slide is this slide right here, the blood supply to the meniscus. And this is why certain people just have chronic meniscal issues, that if you have a tear in this area, and I hope you can see that with my, can you see that with my pointer? That if there's an avascular area. So if you have a tear there, then there's will be no, it won't heal. The tear can't heal. And so here's another slide here, the one on the left, and you can see all these different types of tears. So if you have a tear on the inner side and you have a piece that's flipping around inside the knee, just like this piece right here on the upper left, that piece will never heal, and that will just go on to be the old trick knee or the knee that buckles or gives out. Usually what we do is we go in there with a little shaver and smooth that piece out to try to make it look nice and smooth again. If the tear is on the outer side, that's when you do the repair, and that's when you put sutures in to try to hold that tissue together to get it to heal. People, you know, there's been some controversy about meniscus and whether or not it helps people. Certainly if you have a lot of arthritis in the knee, we don't recommend meniscal surgery. MRIs can be confusing because patients will come and say, oh, I have a tear in my meniscus, but they're bone on bone arthritis. And we know that those people are not having pain because of the arthritis. It's, I'm sorry, because of the meniscus, it's because of the arthritis. So severe arthritis is not great for arthroscopy with a meniscal tear. And if you have no arthritis and you just have a straightforward meniscus, then it's typically, you know, how much pain do you have? How long have you given it to see if it, you know, will quiet down on its own? And also, you know, do you have these other issues like a locking knee, a buckling knee, inability to straighten out your leg? Baker's cyst, one of the most common issues with the knee, swelling in the back of the knee. Basically, I'll tell people it's like a hernia in the back of their knee where there's fluid escaping into the back. It can give you pain with trying to straighten it out. Fluid escaping into the back, it hurts to bend. It causes stiffness of the knee. Basically what you can do is you can put a needle in and aspirate it. Here's an MRI, put a little needle in, aspirate it. You could also try some cortisone into the knee. And this is a pretty rare surgery, but you can actually, here's a surgery where you take out the Baker's cyst when it gets pretty big, but usually not needed. Surgery is usually not needed. Aspiration if it bothers people. And the most common thing is just not to do anything. That the cyst, if it's small enough, you don't have to actually do anything. MCL by itself, pretty rare by itself, but you can see MCL tears grade 1, grade 2, grade 3. Grade 3 is if it's completely ripped, and it's rare to do surgery. Sometimes you do need to do surgery, but it's usually non-operative treatment. And then this is the surgery. You'd reattach the ligament. Where is it? Right here, reattaching the ligament. And again, recovery for that is, you know, can be 4 to 5 months to, you know, bracing, gentle range of motion, and healing with a brace and physical therapy. ACL, most common issue. Most important ligament really in the knee to prevent instability. If your knee buckles without an ACL, then you damage the meniscus. When you damage the meniscus, you can go on to develop arthritis. This is a picture of what we do with it. We reattach the ligaments inside. This is an MRI showing a complete disruption of the ACL. Rehab is extensive. It's first 6 weeks of sedentary activity, and then followed by 2 months of gentle activity, and then 6 months for return to heavy activity like sports, twisting, pivoting. People will even get better with that, even up to a full year after surgery. Most common thing we see, I think, in the orthopedic office is tendonitis, and I like this slide because it actually shows people what tendonitis is all about. So you see on the right, you have a picture of nice, normal, healthy tendon tissue, and then here on the left, I'm sorry, right in the middle, we have little micro tears of the tendon with the blue cells coming in to try to heal that. Those are the macrophages. Those are the inflammatory cells that actually are trying to remodel these little micro tears. So when I have a 16 or an 18-year-old in the office and I say, you know, you've got tendonitis, and I show them pictures of what it actually looks like, it kind of drives the point home that they, really do need to modify what they're doing to allow it to heal. Typically, it's too much, too fast, too awkward, too long. Things like, piling wood, that's kind of piling wood, a little too much there on the knees and bending, not warmed up enough, stretching, loosening up beforehand is very important. Body position, you see this guy on the ladder, and he looks like he's in an okay position, but it's actually the guy underneath here that might develop some tendonitis from holding him up. Lifting too heavy, be careful with that amount of weight. And then basically the biggest thing is allowing the tendon to heal is the most important thing. If you do, it will heal. It just takes a lot of time. Sometimes tendonitis can take from an acute onset. If you get it within 2 weeks, you can typically take 4 to 6 weeks to heal. The problem is if people come in at 6 months of tendonitis pain, that can take almost up to 6 months to heal. Moving on to contusions. What is an actual contusion? Contusion is where you actually get a bone bruising, and you get this the structures here, the microtrabecular of the bone actually have little fractures in them. So if you look here on this MRI, this is edema or swelling from a fall onto a knee. And sometimes can be very confusing with a meniscal tear. They'll have some minor swelling, they'll have pain along the inner side of the knee, and you get an MRI like this, and this just shows that the bone is swollen because of tiny little breaks in the cancellous bone, and that's what you get fluid in there or blood in there. Can be painful. Pain usually goes away typically within about 3 to 4 weeks, typically with rest and modification. Bursitis, front of the knee swelling and pain. You'll see that the knee itself is not swollen, but you have this lump, you have this egg-shaped structure in the front of the knee. Typically, people can, as opposed to a swollen knee, people can bend their knee fully with this, that they have full range of motion. And it's really just can be an eyesore. As you can see, it's kind of ugly looking. People want to get rid of it badly. They don't like the way it looks. And also sometimes it can bother people, especially if somebody kneels for their occupation. So typically what we would do would be somebody comes in with that kind of swelling. Number one is usually you can see if it goes away on its own. If they're really anxious to get rid of it, we pop a little 18 gauge needle with a 30 cc syringe and draw off. Typically it's about 10 cc's of fluid, 15 cc's of fluid. Sometimes I've had people phone right away, right after they get home, and say the fluid came back within an hour, 2 hours, 3 hours. So we always tell them there is that risk that it could come back. You can put cortisone into these. You try not to. Again, cortisone right near the tendon can get issues with the tendon. But then if somebody still has an issue, they still, you've tried to aspirate it maybe twice, You don't want to risk infection by keep aspirating it. You can actually, you can see here on the MRI, you see this is the fluid, and it's not inside the joint, it's outside the joint. It's not doing any damage to the joint, and that's sometimes just what people want to know, that they're not causing any damage. But you can pop a needle in there if needed. And again, if the aspirations aren't working anymore, then this is what it is. It's the lining of the joints. When somebody falls on their knee, the lining of the joint gets disrupted, and you get this fibrous, gunky tissue, or the lining of the patella between the skin and the patella gets irritated, and that's what it actually looks like. If you feel it, sometimes you'll feel these little, these little fibrous structures, and that's what the fibrous structures are. People think they're like loose pieces of bone, but they're not. Patella dislocation, subluxation. This is typically where somebody's twisting, pivoting, and some people will feel their kneecap shifting. They'll feel it shifting off to the side of their knee. And then if you look on this slide, sometimes it goes all the way off to the side of the knee, and they can dislocate, and then you can pop it back in. What happens is you tear the ligament that goes from the patella to the femur. And let me go back there. And so typically one dislocation is usually physical therapy. If it happens again, usually I would recommend surgery to try to keep that patella, prevent that patella from dislocating again. And that's what the surgery is right here, where you reconstruct that ligament that goes from the femur to the patella, or it's called the patellofemoral ligament. And again, that's kind of like an ACL recovery, about a 4 to 6 month recovery to prevent any further subluxation. The reason why you don't want the patella to keep subluxing and you don't want people to keep going is that you can get chip fractures or pieces of bone off the patella, and those can form loose bodies and float around in the knee. Arthritis, most common thing we see as orthopedists, joint surface abnormalities here. Loss of cushion, that's the definition of arthritis, loss of cushion, normal joint x-ray, severe joint x-ray. This is what sort of patellofemoral syndrome is, where it's more of early arthritic change under the kneecap here as the kneecap flexes. So somebody, again, coming in with that anterior knee pain, it's typically either early arthritis, late arthritis. We'll get x-rays. This is a beautiful normal patellofemoral joint here, and this is severe patellofemoral arthritis. When people squat or lunge, the kneecap gets driven up against the femur, causes pain. Typically for any arthritis or patellofemoral arthritis, it's physical therapy, pills, injections, cortisone, sorry, I spelled that wrong, cortisone, viscosupplementation, platelet-rich plasma, or knee replacement if it's ugly and severe. Somebody showing up with a swollen knee is, you can, if you sort of don't know the diagnosis or you're suspicious of other things going on, then aspiration. When we aspirate, we'll typically send people for crystals, crystal analysis, pseudo-gout crystals, lime titer, just because I've seen it with anything. It can be very deceiving for Lyme, but it's still pretty rare on all the people that come in with a swollen knee, and gram stain culture and cell count. Patella tendon, again, you guys in the primary care setting probably not seeing these as much. This is more of an emergency room situation where somebody falls, they can't lift their leg up, their tendon is torn from the patella or up in the quadriceps tendon. And typically that is an absolute indication for surgery to reattach the tendon. These are loose bodies. This is what a loose body looks like. If somebody feels this, they can feel sometimes a little marble floating around in their knee. They'll say they can play with this little marble that floats around in there. Or you can have this osteochondral defect. We have a piece of cartilage that is flipped around in the knee. You can do cartilage transplantation for that, or this other thing, excuse me, called an Oates procedure, where you take a block of cartilage, drill a little piece, and then you put that drill with bone and cartilage into the defect, and you can reattach it. 1249, John. Pretty good.
Thanks, Sean. That was really great. You guys have any questions for Sean about the knee or any other orthopedic questions? Feel free to throw them into the chat box. Sean, you know, one of the things we struggle with as primary care providers is trying to figure out, you know, what the next step is when someone comes in limping with the knee and it's swollen.
Yeah.
You didn't, you know, you didn't spend much time on kind of some of the maneuvers you like to do. I wonder if you could spend 2 or 3 minutes talking about some of the maneuvers you like to do to try to figure out whether there's actually a tear besides the history and other maneuvers that you find valuable.
Yeah. So, you know, so most common thing we see is, you know, medial meniscal tear, sometimes lateral meniscal tear. That is typically twisting, pivoting pain with squatting, and it's called, you know, the McMurray is, I can get my knee down here. You know, joint line tenderness, pain with hyperflexion. So I'll have the person lie down, I'll bend their knee, hyperflex them. If they tell me the pain is in the back of their knee, that's sort of high suspicion for a meniscal tear. And then the other part is the McMurray, where you rotate, I'll rotate the foot and then stress their leg and you know, give them what's called a valgus stress, where if you look here, you're pushing and straightening out the knee at the same time with a valgus stress. And if they can tell me that pain, you know, is elicited, the pain that they had is, you know, medial inside or in the back, then that's typically, you know, meniscal. The Lockman is a tough test. That's a test for an ACL, and, you know, even experienced orthopedists, you know, that's a Lockman where you're taking the person's, you're holding their femur and then you're pulling up on their tibia. If this is the knee joint, you're pulling up on the tibia to try to assess Lockman. When someone's try to assess their ACL. When someone has a big swollen knee, it's very difficult sometimes to assess the ACL. But once the swelling diminishes, you know, you can pick up that laxity. The other test is called the pivot shift, and again, that's a difficult test. But what you're doing is you're creating the instability, the pivoting of the knee. So those are some of the things. And also quad tear or patella tendon tear. First thing, you know, just can they do a straight leg raise? Can they lift their leg up off the bed?
Right. Do they typically, with the quad tear, they typically will talk about a popping sensation, right, during that injury, or? Yeah,
it's a rip. You know, similar to the Achilles. Someone will say, you know, I got hit in the back of the knee. You know, they'll feel the same, like sudden rip, sudden pop. Like they'll literally say a ripping sensation. ACL, 70% of ACL tears feel a pop or hear a pop. So that's another sort of diagnostic tool that you could use.
And how do you counsel your patients? You know, I think I've asked this of other orthopedic surgeons as well about, you know, a lot of people like to wear braces either after injury or pre to prevent injury, especially in the folks who do the stop-start sports. How do you counsel your athletes about that kind of bracing, either pre-injury as a prevention or after you do a mild repair on their knees?
Yeah, what I've found is people like it initially during their first year or year and a half of recovery. It gives them a sense of stability and confidence. And half the battle with the ACL is the mental aspect, that people are having trouble mentally getting back because they remember that pivot, they remember that clunk, and they don't like it. And so having the ACL or having the brace there initially, at least for the first year and a half after surgery, is helpful. And then I'll let people get rid of it after that if they feel strong enough and confident enough to get back.
And you don't limit those folks. They can go back. I mean, we've certainly seen plenty of professional athletes go back after ACL.
Yeah, that's why we do it. That's why they're there.
And then in my practice, certainly I've had a lot of folks who have ACL tears who obviously aren't professional athletes, and you tell them, you know, just go easy and let me know if it kind of becomes unstable.
Are you saying if you say
no repair?
They have an ACL with no repair? Yeah, there's some ACL tears are partial. Some ACL tears are stable, and then people aren't very active, and people are saying they can bike and run, which is typically fine. But you know, if they're going to get back to, you know, tennis, skiing, basketball, soccer, then I'll encourage them to have an ACL reconstruction. Yeah.
Okay, and then there's a question in the chat box about a Baker's cyst. Do you mostly just leave those alone? It seemed like that's what you were hinting about in the slides.
Yeah, Baker's cyst is again, it's people focus on it because they have pain and they hear, oh, I have a cyst, and cysts usually don't cause pain. They either cause limitations in motion or tightness. It's usually not a painful thing, and so people latch on to, you know, they think that the Baker's cyst is causing pain, but it's usually not. If it's small, you know, meaning like a quarter size or less, people usually don't feel that. If it gets to be a golf ball or a racquetball size, that's annoying. People don't like it that big. And then we can get into aspiration. And again, it's really rare to take it out surgically.
And do you find that you have the same issue like with infection kind of protocols with draining bursa versus the Baker's cyst, or is it a similar kind of risk?
I think I've seen more. I haven't seen Baker's cysts get infected, you know, with aspirations. I've seen more Patella bursitis coming in with infected bursas, you know, just de novo, you know, just having fluid in the front of the knee. But I've definitely haven't seen Baker's cyst get infected. Yeah.
Great. Couple more minutes. You know, I'll continue to ask Sean all my knee questions if nobody asks me, so that's awesome. The other thing I struggle with at least is, you know, the kind of, you put in a timeline about chronic knee arthritis, and certainly my patients are always asking me when they should get their knee done kind of thing.
Yeah.
I saw your kind of protocol. I see now platelet-rich infusions are now becoming mainstream. Are you doing a lot of those in your office, and what's your feeling about those?
Yeah, so we're doing them. We do them in our office. There are some good orthopedics, you know, controlled studies that are showing that people did better than cortisone injections without the side effects of cortisone. So initially I was skeptical. I was very skeptical, you know, just thinking, you know, how is this helping? But none of this is growing anything back. There is no regrowth of anything. It's the anti-inflammatory properties that are in it. But yeah, I've had success with giving it to people, and we do it in our office. It's you know, you basically just draw blood, spin it down, and inject it. And I mean, I think insurance companies are going to come around to it.
Right now, it's still mostly not a covered procedure, is my understanding. Is that correct? Yeah.
Yep.
So you like to do the cortisone, and then if the cortisone either fails or they come back within like a 6-month window, you do the visco supplementation, and then if that doesn't work, the platelets?
That is typically my protocol, yeah. Yeah.
Great.
Yeah.
All right. Well, Sean, thanks so much for showing up here on our Lunch and Learn series. We appreciate it. Everyone, I'm sure on this call knows Sean, Dr. Rocket, and his group has an expansive group of podiatrists, PMR physicians, joint replacement physicians, as well as sports medicine docs. So great group. What are you up to? 3 different offices now, Sean? I think so.
Yep. Yeah.
3 different offices. One right here on our campus.
Right.
Beautiful office right in the Bean Street, right by the Natick. What's it called now? The Natick Mall. It used to be the Natick Collection.
Yeah, the Natick Mall, and then we have an office out in Hopkinton too, right at Lumber Street, which I just went to. It's beautiful.
Excellent. Well, thanks so much, Sean. Everyone have a great weekend. We'll see you all here next week to talk about data integrity on our notes, and hope everyone has a wonderful weekend. Bye.
All right. Thanks for having me.
Okay, Sean.